Imagine standing on a crowded subway when your vision blurs, your chest tightens, the environment warps, and an overwhelming certainty of death floods your system. The universal clinical response to this terror is to teach the patient how to calm down. For decades, practitioners have used deep breathing exercises and progressive muscle relaxation to manage the attack. Modern evidence synthesis, covering over 136 randomized controlled trials, contradicts this practice. This visualization compares therapeutic outcomes. On the left, clinical guidelines recommending breathing retraining. On the right, a forest plot reveals negative impacts on recovery. Adding breathing retraining to cognitive behavioral therapy actually decreases the therapy's overall efficacy. This Sukra ranking curve illustrates the hierarchy of treatment effectiveness. Applied relaxation sits near the bottom, while interoceptive exposure holds the top position. The failure of relaxation techniques is rooted in the mechanism of safety behaviors. Using a breathing technique to control an attack reinforces a subconscious belief that the bodily sensations are genuinely dangerous and that the technique is the only thing preventing a catastrophe. Relying on these behaviors prevents the patient's brain from learning that a panic attack will peak and subside harmlessly on its own, regardless of intervention. Curing treatment-resistant panic requires a transition away from calming the patient. Remission is only achieved by intentionally triggering the physiological alarm. Panic vulnerability is a quantifiable biological architecture rooted in systemic enzymatic dysregulation. This pathway map shows the folate cycle. MTHFR mutations prevent proper folate conversion, blocking the pathway. This bottleneck causes universal methyl donor SAMe production to plummet. This deficit starves the COMT enzyme, which requires SAMe to function. In individuals with the slow COMT polymorphism, cofactor starvation prevents the enzyme from clearing excitatory catecholamines from the synaptic cleft. This creates a chronic, systemic accumulation of dopamine and norepinephrine, resulting in a hyperadrenergic baseline. This biochemical state reduces high-frequency heart rate variability, which serves as a proxy for parasympathetic vagal tone. A low high-frequency score indicates an impaired vagal brake, leading to a state of autonomic rigidity. In this state, the cardiovascular system cannot smoothly adapt to routine physiological shifts. The panic-prone nervous system is biochemically locked, abruptly binary shifting into full sympathetic overdrive the exact moment stress is applied. This rigid baseline sets the stage for a specific biological trigger. Dr. Donald Krine's suffocation false alarm theory suggests the brain contains a sensitive physiological monitor for asphyxiation. Laboratory data supports this. A chart compares panic induction rates during a 35% carbon dioxide inhalation test between panic disorder patients and healthy controls. It yields a massive 3.524 odds ratio for inducing panic, confirming a profound sensitivity to carbon dioxide. Acid-sensing channels in the amygdala register minor drops in brain pH as carbon dioxide levels rise. Single-cell RNA sequencing confirms that individuals predisposed to panic possess hypersensitive afferent neurons. These neurons send amplified distress signals directly from the heart and lungs to the brain during routine physiological fluctuations. The hypersensitive brainstem misinterprets these minor shifts in lactate or carbon dioxide as impending asphyxiation. This triggers a massive, unstoppable survival reflex, rapid hyperventilation, acute respiratory distress, and the overwhelming urge to flee. The initial wave of a panic attack is a raw, high-fidelity biological reflex that bypasses the cortex entirely. Experiencing a biological false alarm does not guarantee a diagnosis of chronic panic disorder. The transition to a chronic state requires a psychological vulnerability called anxiety sensitivity. This is the trait-like belief that the physical symptoms of anxiety are inherently dangerous and will lead to a catastrophe, like a heart attack. Classical interoceptive conditioning locks this belief in place. A flowchart maps how an unconditioned stimulus generates an unconditioned response. For example, a severe childhood asthma attack produces intense breathlessness, the unconditioned stimulus, which elicits absolute terror. Eventually, a benign shift, like climbing stairs, becomes a conditioned stimulus that involuntarily triggers the full panic response. Early childhood traumas, like separation or parental loss, leave a permanent biological scar by dysregulating the endogenous opioid receptors that calibrate the suffocation alarm. This trauma-induced dysregulation provides the foundational architecture for adult respiratory panic and emotional instability. Breaking this conditioned loop requires directly attacking the fear of somatic sensations rather than attempting to calm the body. At the peak of the efficacy hierarchy is cognitive behavioral therapy that utilizes interoceptive exposure. This protocol yields a staggering 7.69 odds ratio for remission compared to therapies that exclude exposure. Interoceptive exposure is the systematic induction of feared physical sensations within a safe, controlled environment. Modern protocols often use brief, intermittent, intense exercise to operationalize this. The patient executes a high-intensity sprint to intentionally force tachycardia, sweating, and dyspnea. Bypassing abstract cognitive restructuring to directly trigger the fear circuit prevents intellectualization and avoidance. This process facilitates inhibitory learning. Repeatedly experiencing somatic arousal without a catastrophe forces the brain to rewrite the threat code. The feedback loop between the stimulus and the terror response begins to fracture. As the conditioning link breaks, heart rate and respiration metrics stabilize, and the system returns to homeostasis. For patients with the permanent biological scars of childhood trauma, short-term psychodynamic psychotherapy targets the underlying emotional conflicts that originally calibrated the hypersensitive suffocation alarm. Remission is not the elimination of anxiety or the achievement of relaxation. It is the forging of absolute autonomic tolerance, the ability to experience extreme physiological signals with objective, non-reactive detachment.